between the right atrium and the right ventricle, we have the tricuspid valve, and between the right ventricle and the pulmonary artery, we have the pulmonic valve. So we will discuss the most important abnormalities which we encountered in our routine practice. First, we will discuss about the mitral stenosis. Mitral valve, which is situated between the left atrium and the left ventricle, uh, when the valve area it is less than 2.5 centimeter squared, we will call it as a mitral stenosis. The normal mitral valve area is about 4 to 6 centimeter squared. This is a condition which is called the rheumatic heart disease, in which the patient have a repeated exposure of sore throat because of the group B streptococcus infection, and these patients they ultimately they may develop the rheumatic heart disease. And the mitral valve is the valve which is most commonly involved in the rheumatic heart disease. So rheumatic heart disease is the commonest cause of mitral stenosis. And in rheumatic heart disease, the mitral valve, it is become thickened, it become calcified, and because of that, the valve area gets narrow. So when the valve area is less than 2.5 centimeter square, we call it as a mitral stenosis. The normal mitral valve area is about 4 to 6 centimeter square. Rheumatic heart mitral stenosis is more common in female as compared to male. Here you can see that this is the mitral valve, which is now it become quite thickened, calcified, and the valve area has now become just like a slit-like. So it is very much severely narrowed. So most of the commonest cause of mitral stenosis is the rheumatic. Majority of patient, 90 to 95% of the cases is of because of rheumatic heart disease. The less common cause is the congenital sometime causes. So in mitral stenosis, when the patient has the mitral stenosis, the mitral valve gets narrows, and because of that, the left atrial pressure rises because the blood is now unable to completely fill from the left atria to left ventricle. So blood retains in the left atria, and that causes the rise in the left atrial pressure. And the left atrial pressure rises, and ultimately the left atria is also dilated. And because of that, the patient develops the pulmonary venous pressure rises, and ultimately this pulmonary venous because the pulmonary veins they are opening in the left atria. So when the left atrial pressure rises, this pressure transmitted back into the left into the pulmonary veins. So pulmonary venous pressure rises, and ultimately this pulmonary venous pressure then reflects back into the pulmonary capillaries. Pulmonary capillary pressure rises, and that causes the shifting of fluid. Because of this high pressure in the pulmonary capillaries, the fluid comes into the alveoli and causes the pulmonary edema. If the patient remains untreated, then patient may also develop the pulmonary hypertension. The pulmonary artery pressure also rises, and when the pulmonary artery pressure rises, the pressure on the right ventricle also rises, and ultimately the patient may also develop the right ventricular failure. So the symptoms of mitral stenosis are usually dyspnea. Initially, it is dyspnea may be at rest, and as the disease progresses, the dyspnea on exertion also develops. The patient may also develop orthopnea. Orthopnea indicates when the patient becomes lie down, he becomes short of breath. Patient may also develop the paroxysmal nocturnal dyspnea. In paroxysmal nocturnal dyspnea, the patient wakes up at the early morning at about 3 to 4 a.m. because of the shortness of breath. And if the patient remains untreated, the patient may also develop the sign and symptoms of the right ventricular failure, which includes the pedal edema, ascites, raised JVP, tender hepatomegaly, and all this thing. And sometimes the patient may also develop the hemoptysis because of the severe pulmonary edema. Comes on to the signs. First on the pericardial examination, the apex speed is usually at its normal position. That is in the fourth or fifth intercostal space at the mid-cavity. It is usually not deviated if the patient has a pure mitral stenosis. If the patient have concomitant other pathologies like mitral regurgitation or aortic stenosis or aortic regurgitation, then the apex beat may be shifted. Otherwise, in pure mitral stenosis, the apex beat remains in its normal position. On palpation, the patient may have a thrill, and that will be a diastolic thrill because the mitral stenosis happens in the diastole. So all the findings of murmur and all this thing, they will appear in the diastole. That have to be remembered. And there will be a thrill. This thrill may or may not be present. Most of the time, this thrill is not present. It's a very less percentage of patients which may have a thrill. The most common finding is on the auscultation. On auscultation, the patient may have loud S1. The S1 sound will be loud, The P2 sound may also be loud depending upon the pulmonary hypertension. If the pulmonary hypertension is there, then the P2 may also be loud. Now, in mitral stenosis, normally the opening of the valve does not create the sound. The closing of the valve create the S1 and an S2. The opening is very smooth process. But here in rheumatic heart disease, because the valve is very much thickened, calcified, so because of that, when the mitral valve opens up, then a sound is appear, and that sound is called the opening snap. So this sound will be just like a S1 and an S2. This will be a sound, not the murmur. This will be a sound, and this sound will be appear just after S2. That means it is in the early part of the diastole. Okay, and then the patient may also have the murmur, and that murmur will be a diastolic murmur, and this murmur will be at the apex, and because all the mitral valve is very close to the apex, so the murmur of mitral stenosis will be auscultated at the apex. Now this murmur will be very much soft because this is a low pitched murmur. So we have to take certain step. First, we have to palpate the apex beat and then pinpoint with the one finger, and then we use the bell of the stethoscope, not the diaphragm. For the mitral stenosis, we have to use the bell of the stethoscope, and we will put the bell at the point where the apex beat was felt. And then we will ask the patient to tilt slightly laterally. And fourth one is that we ask the patient to take a deep breath, exhale, and then hold it. So we will auscultate the murmur on in expiration, because all the murmur of the left sided of the heart, which their intensity is increased during expiration, whether it is mitral murmur originate from the mitral, whether it is mitral stenosis or mitral regurgitation, or it originates from the aortic, whether it is aortic stenosis or aortic regurgitation. All the murmur which originate from the left side of the heart, their intensity increase during expiration. So we will take 4 steps for auscultating the mitral stenosis murmur. Apex, localize the apex beat, pinpoint with the finger, put the bell of the stethoscope at the point of apex beat. Third, slightly shift the patient towards the left lateral side. And fourth, ask the patient to take a deep breath and exhale and then hold it, and then we will auscultate the murmur. So there will be a diastolic murmur at there. Presystolic accentuation, sometimes when in the last phase of the diastole, the atrial contraction happens. And because of this atrial contraction, there will be a slight increase in the intensity of the murmur in the late phase of the diastole. That is called the presystolic accentuation. Okay. Uh, and then if the patient have a long-standing mitral stenosis, then the signs of the right heart failure may also be there. And if the signs of right heart ventricular failure include, the precordial thirst will be appear. In precordial thirst, we will put the hand over the left side of the sternum, and then there will be a thirst feeling inside of the heart, and that is called the precordial thirst. There may be elevated JVP, ascites may be there, and the pedal edema may be there. So these were the signs of right heart failure, and they will only be present if the right heart failure is present. Normally in mitral stenosis, these signs are not present. They only be present if the patient have a very long-standing untreated mitral stenosis. On ECG, there may be atrial fibrillation, because in mitral stenosis, the left atrium gets dilated. And when the left atrium gets dilated, then the fibrosis develops in the left atrial wall, and that impaired the conduction, and that will precipitate the atrial fibrillation. So on ECG, the atrial fibrillation will be there. And here you can see this is the ECG, which is showing the atrial fibrillation. And the signs of atrial fibrillation on ECG, these include, like here, this is the long lead 2 in the lower part, and here you can see that there is no P wave. We can't appreciate. Now this is the QRS, this is ST, then the T wave, and then there is a TP segment, but there is no P wave. Again, there is a QRS, ST segment, T wave, isorectic line, but no P wave. So absent P wave, this is the first sign. Second sign is that the RR interval is irregular. Normally, in sinus rhythm, the RR interval, the interval between the two R wave, in sinus rhythm, it is equal, but here you can see it is unequal. Sometimes the RR interval is wide, sometimes the RR interval is narrow. So there is a irregular RR interval. So these are the two signs: absent P wave and irregular RR interval, which are the hallmark sign of atrial fibrillation. So on ECG, atrial fibrillation may be present if the patient has atrial fibrillation. The P mitral sometimes may be present in P mitral in long lead in lead 2. In lead 2 here on lead 2 the P wave will be wide. It will be more than 3 small square wide and it may be bifid in shape. That is called the P mitral. So because of the left atrial enlargement, P mitral may be there. And then on ECG, sometimes there may be signs of pulmonary hypertension, and that include the right axis deviation. So in right axis deviation here, here you can see there is the right axis deviation is present. In lead 1, you can see there's a small R wave and the big S wave. In lead 2, there is a predominant R wave. So normally in lead 1 and lead 2, there's a predominant R wave. But here you can see in lead 1, the R wave is small and the S wave is larger. So this is a right axis deviation. So on ECG, there may be right axis deviation, and sometimes there may be a R wave in V1, it will be greater than the S wave. Normally, like here, you can see that the R wave is small and then the S wave is larger, but in right ventricular hypertrophy, the R wave will be larger than the S wave in lead V1. So this sign may also be present. Now comes on to the chest X-ray. Normally here you can see the chest X-ray, and normally this is the right heart border, and this right heart border, it is formed by the right atrium. This is the left heart border. The lower part, it is formed by the left ventricle, and this is the upper part of the left heart, which is formed by the left atrium. Now normally this upper left heart border, it is slightly bulging inside. The slight convexity is there normally. In left mitral stenosis, because of the enlargement of the left atrium, this bulging is lost and the heart border becomes straight. Here, like in this chest X-ray, you can see there is a straightening of this is called the straightening of the left heart border. This bulging has been lost and the left atrial border is also become straight, just like the left ventricular border. So this is a straightening line, and this is called the straightening of the left heart border, which may be seen in case of mitral stenosis. Sometimes there may be pulmonary congestion is there, pulmonary venous marking prominent, infiltrate may be there. That may be because of the pulmonary edema. Now, this is an echocardiogram here. This is an echocardiogram, and you can see this is the left ventricle. This is the left ventricle. This is the left atrium here. This is the posterior wall of the left ventricle. This is the interventricular septum. This is the right ventricle. Here is the aortic valve. So this is the pulmonic valve between the left atria and the left ventricle. This is the pulmonic valve. Now you can see here is the pulmonic valve. It is thickened. Normally it's a very thin structure, but here you can see it is quite thickened. It is calcified. It is bright. Since this brightness, it is because of the calcium. So this is calcium is deposited there. It is thickened and calcified. And here you can see the valve area. The two leaflets, when it opens during the diastole, here you can see that is a very small area is there. Normally, when the valve opens, there is a very wide area, but here you can see that the area when the valve opens during the diastole, no, this is closed. This is a systolic closed, and during diastole it opens up. And when it opens, you can see that the valve area is very small. Now this is the anterior mitral valve leaflet, and this is the posterior mitral valve leaflet. So there are two leaflets, anterior and the posterior. Now anterior mitral leaflet, when it opens up, you can see that is slight. This portion is fixed, and this portion is only moving. This is here its appearance, which is we call as the hockey stick appearance. Now when it opens up, then this anterior mitral leaflet have an appearance of hockey stick. This is called the hockey stick appearance, and this is again a very good sign for diagnosing the mitral stenosis. Now comes on to the management. So echocardiogram is the gold standard test for diagnosing the mitral stenosis. Comes on to the management, and the most important part of management is the rheumatic fever prophylaxis. Especially in case of mild to moderate mitral stenosis, the prophylaxis must have to be given in order to prevent the progression of the disease. The best antibiotic for rheumatic fever prophylaxis is the benzathine penicillin. The dose is about 1.2 million units, and this 1.2 million units is given intramuscular and given every 3 to 4 weeks. In children, the dose will be 0.6 million international unit. Some patients, they are allergic to penicillin. So if the patient is allergic to penicillin, then we will, instead of giving penicillin, we will give some alternative antibiotics like erythromycin, sulfadiazine, cephalosporins. They may also be used, but the best antibiotic regime is the benzathine penicillin. No, if the patient have any complications, like if the patient have atrial fibrillation along in mitral stenosis, then we have to treat the atrial fibrillation. And for anticoagulation, for atrial fibrillation, we have to anticoagulate the patient. We will give the warfarin to the patient as an anticoagulant, and we will give the beta blocker or calcium channel blocker to control the heart rate, or sometimes digoxin may also be given. So digoxin, beta blocker, or calcium channel blocker, any one of these, and sometimes combination of these drugs will be given in atrial fibrillation to control the heart rate, and we will also give the anticoagulation to these patients in mitral in if the patient has atrial fibrillation along with mitral stenosis. Then, if the patient has congestive heart failure, then patient have the shortness of breath and all shortness of breath, dyspnea, orthopnea, PND. Then we will give the diuretics, and the best diuretic is the furosemide. So anticoagulation may also be given if the patient has atrial fibrillation, or if the patient has history of CVA or stroke, or if any and thrombus is seen in the on echocardiogram, then we have to anticoagulate. And the best anticoagulation which we use in mitral stenosis is the warfarin. The new oral anticoagulation, that is rivaroxaban, dabigatran, we will not use in usually in patient with mitral stenosis, but we use the warfarin. No, if the patient is has moderate to severe mitral stenosis and patient is symptomatic despite of medical therapy, then we use a technique which is called the PTMC. PTMC stands for percutaneous transmitral commissurotomy. The other name of this technique is the percutaneous balloon valvuloplasty. The same name for the two indication. So if the patient has are symptomatic, have any NYHA class 2, 3, or 4 symptoms despite of medical therapy, an echocardiogram shows the mitral to severe mitral stenosis, then we usually perform the procedure which is called the PTMC. In PTMC, we pass a catheter through the femoral vein. Through the femoral vein, it retrogradely goes into the inferior vena cava and then reach the right heart, from where we puncture the interatrial septum. And between the left atria and between the left atria and the right atrium, there is the interatrial septum. So when the catheter is reached into the right atrium, then we pass a needle through this catheter and we puncture the interatrial septum. And so the needle reaches into the left atria, and then over the needle we pass the catheter, then we remove the needle, and then we pass a balloon through this catheter, and then this balloon will be placed at the level of mitral valve. This balloon is outside of the body, is attached to a device, and through this device we inflate it, and the balloon is inflated, and mitral stenosis gets relief. This technique is called the PTMC. But there are certain people who are not good candidate for the PTMC. So there are some contraindication. One, first, if the patient, if the valve is very much calcified and non-viable, it is very thick and very calcified, then it is unable to open with the balloon, and we usually do not refer these patients for the PTMC. If there is subvalvular distortion, if the chordic tendon is very much thickened, calcified, shortened, then again the procedure is not situatable. And if the patient has significant mitral regurgitation, if the patient has mild mitral regurgitation or there is no mitral regurgitation, then we can refer the patient for the PTMC. But if the echocardiogram shows the moderate or severe mitral regurgitation, then by the PTMC this regurgitation can be worse, and so we avoid the PTMC when the patient has significant mitral regurgitation. Along with that, if the patient has thrombus in the left atria, then again the PTMC is not advisable, because this thrombus can go into the systemic circulation. So if the thrombus is there, then either we have to anticoagulate the patient for 4 to 6 weeks, and then we will repeat the echocardiogram, or we will send the patient for the surgical mitral valve replacement. So here, this is the technique of the PTMC. You can see the catheter is passed through the femoral vein and then ultimately reaches into the right atrium when we puncture the interatrial septum, so that the balloon is then we will place it at the level of the mitral valve. Then we will inflate this balloon. So by inflating the balloon, as you can see, this is the balloon which is initially start to inflate here, and here on the last diagram you can see the balloon is completely inflated, so that by the inflation of the balloon the mitral stenosis gets relieved. Now, sometimes when there is a contraindication for PTMC, which we have just discussed, then we will send the patient for the surgery. In surgery, there is an old technique which is called the open mitral valvuloplasty. In open mitral valvuloplasty, the surgeon usually made a small incision on the chest. Through that incision, the left atria is then open up, and through that left atrial opening, the dilator was placed at the level of the mitral valve, and then with that dilator, the valve was valvular. Mitral stenosis was released. But this technique, this open mitral valvuloplasty, nowadays it is almost obsolete because this has been now been replaced by the percutaneous transmitral commissurotomy. The surgery usually which we done right now is a mitral valve replacement. When the valve is very much thickened, calcified, or when the significant mitral regurgitation is present, then the surgeon open the left atria, remove this mitral valve, and insert a new valve. So mitral valve replacement is indicated when the mitral stenosis is severe, when the valve area is less than 1 centimeter square, if the patient has symptomatic and patient is not a candidate for the balloon valvuloplasty, then we send the patient for the surgery. Now comes down to the mitral regurgitation. Mitral regurgitation happens during the systole. During the systole, the mitral valve closes. During diastole, the mitral valve opens up. Now, if the valve is unable to close properly because of some disease process, then the mitral regurgitation takes place. So the mitral regurgitation takes place during the systole. Now, in mitral regurgitation, the early or compensated, in the initial part, there is just a volume overload. Be- be- because the blood regurgitates from the left ventricle to the left atria, so the left atrial blood volume increases. Then in the next cardiac cycle, this left atrial blood will goes into the left ventricle again. So a large volume of recirculation happens on the left side of the heart, and so this causes the volume overload, and that ultimately causes the enlargement of the left atria as well as the left ventricle. So ultimately the left atrial enlarged, the left ventricle can also be enlarged, and that ultimately causes the decreased function of the left ventricle. So the left ventricle ejection fraction reduces, and because of the increase in the LA pressure, the pulmonary congestion may also be developed. So for the causes of mitral regurgitation is very long listed. The one of the common cause is the rheumatic heart disease, but in Western countries, the most common cause is the mitral valve prolapse. In mitral valve prolapse, the mitral valve is weak because there is a deficiency of elastin and collagen fibers, and because of that deficiency, the mitral valve is weak. So the mitral valve during the systole, when the mitral valve has to be closed, it will be unable to close, and the weak portion of the mitral valve will prolapse back into the left atria, and that will create a gap between the two leaflets, and through this gap then the blood will be regurgitated. So the mitral valve prolapse is a common cause of the mitral regurgitation. Then the other causes include the ischemic heart disease and papillary muscle dysfunction because of the ischemia. Now, the other causes are left ventricular dilatation, mitral annular calcification, hypertrophic cardiomyopathy, infective endocarditis, and there is a congenital mitral regurgitation may also be there. So here you can see this is the mitral valve, this is the left atria, and this is the left ventricle. This is the mitral valve, which is attached with the chordae tendineae to the papillary muscle. These are the papillary muscle, these are the chordae tendineae, and this is the two leaflets. Now, one of the causes is the mitral valve prolapse. In mitral valve prolapse, the weak part of the valve will prolapse back into the left atria during the systole, and because of this prolapse back, there will be a gap between the two leaflets, and through this gap then the blood will regurgitate back into the left atria during systole. Here another cause is the flare leaflet. In flare leaflets, this is just like a prolapse leaflet, but here in flare leaflet it is a more severe form of the mitral valve prolapse. The whole of the valve can be prolapsed back into the left atria, and there will be a large regurgitation between the left ventricle and the left atria. Then the functional MR. In the functional MR, the valve leaflet itself is normal. There is no as such pathology, but the left ventricle is dilated, and because of this dilatation of the left ventricle, the mitral annulus. Annulus is a ring-like structure which is through which the mitral valve is attached, and this annular dilatation and the left ventricular dilatation causes the mitral regurgitation. So in functional MR, the functional MR is also called the secondary MR. In this functional MR, the mitral valve leaflet is normal, but the left ventricle or the mitral annulus is dilated, and that causes the regurgitation. So the dyspnea, the symptoms will be the same, just like in mitral stenosis. There is dyspnea, there will be a fatigue, there will be weakness, cough, and all that symptoms. In signs, The apex beat may be hyperdynamic. Because of this, there is a hyperdynamic circulation on the left side in mitral regurgitation, so there will be accentuated and displaced. So, and because the left ventricle may also be dilated, so the apex beat may be shifted laterally and it will be hyperdynamic. There may be a thrill, may be feel at the apex in some cases, not always, but in some cases, if the mitral regurgitation is severe, then the thrill may be feel, and this thrill will be systolic because mitral regurgitation is happening in the systolic, so all the finding will be in the systolic. The S1 will be soft. In mitral stenosis, it was loud, but here it will be soft. The P2 will be loud, and there may be sometimes there may be S3 gallop rhythm may be there. That is in the severe disease. S3 sound may be present. The most important finding will be the murmur, and this murmur will be a systolic murmur. And this will be a holosystolic, and depending upon the severity, it may be a pansystolic murmur. And again, this murmur will be the intensity will be increased during expiration. This murmur will be heard at the apex, and sometimes the murmur may be radiated to the axilla. So the murmur may also be auscultated in the axilla. Here you can see on the chest X-ray, because the left ventricle may be dilated, so cardiomegaly may be there. Here you can see this is a chest X-ray of the mitral regurgitation, and you can see the huge cardiomegaly is there. In mitral stenosis, the left ventricle size is usually normal, so cardiomegaly is not there. Just only the splitting of the left aorta can be seen. But in mitral regurgitation, the left ventricle may or may not be dilated. Here you can see there is a massive cardiomegaly there. Now this is an echocardiogram, and in echocardiogram you can see this is the left ventricle, this is the left atrium, this is the right atrium, this is the right ventricle, this is the interventricular septum, this is the mitral valve. And in mitral valve here you can see we put a color Doppler, which in echocardiogram there is a technique which is called the color Doppler. When we put the color Doppler, then we can see the regurgitation. Here you can see a large color regurgitation jet is seen. This is the mitral regurgitation jet, and that indicates that this patient has a severe mitral regurgitation. So echocardiogram is the gold standard test for diagnosing the mitral regurgitation. We can see the regurgitation jet. We can estimate the severity of the mitral regurgitation, whether it is mild, moderate, or severe. We can assess the size of the left atria and the left ventricle. We can assess the function of the left ventricle and all these things. Here you can see that this is the left ventricle. This is the left ventricle. This is the left atrium. And here you can see that there may be a small gap may be seen between. This is the two leaflet, and where you can see that the small gap is seen, and that indicates that the patient may have the mitral regurgitation through these gaps. On in management, we have to treat the symptoms of the patient. For those who have dyspnea, orthopnea, and all these things, we have to give the diuretics. And in diuretics, the loop diuretics, furosemide is the one which we use more commonly. If the patient has atrial fibrillation, then we can also use the digoxin to control the heart rate. Or if the left ventricular systolic function is severely reduced, then we can also use the digoxin to improve the contractility of the left ventricle. So digoxin is only used if the patient has atrial fibrillation or if the left ventricular function is severely reduced. Otherwise, if the left ventricular function is normal, then there is no need for the digoxin. Afterload reduction may be used in like ACE inhibitors, hydrazine may also be used. This help to improve the symptoms, and if the left ventricular function is reduced, then this ACE inhibitor is also helpful to improve the left ventricular systolic function. IV nitroprusside is only used if the patient has very symptomatic acute mitral regurgitation is there. Patient is very much symptomatic, having severe shortness of breath. Then we can use the IV nitroprusside, and that will help to improve the pulmonary congestion. Anticoagulation is only used in mitral regurgitation if the atrial fibrillation is there. In mitral regurgitation, again the left atria is enlarged. So because of this enlargement of the left atria, the patient may develop the atrial fibrillation. So whenever there is atrial fibrillation, the patient have high risk of developing the thromboembolism. So we have to anticoagulate the patient. Now, surgery is indicated in mitral regurgitation if patient has severe mitral regurgitation. So if the mitral valve, there are two types of surgery. One is the mitral valve repair, and the second one is the mitral valve replacement. Mitral valve repair is done in some cases, like in mitral valve prolapse. So if a portion of the leaflet is prolapsing, then the surgeon resect that portion and close it with a patch, and that repair the mitral valve. But if the mitral valve prolapse is very much severe, or if patient has some diseases like rheumatic heart disease in which the valve is very much thickened, calcified, whole of the valve leaflet, it is difficult to repair, then we surgeon usually remove this valve and replace it with a new prosthetic valve. Now there are two types of prosthetic valve. One is the bioprosthetic valve, and the other one is the metallic valve. In metallic valve is mainly made up of metal. Bioprosthetic valve is usually made of the bovine pericardium, or then bioprosthetic valve is usually does not require long-term anticoagulation. It requires only anticoagulation for only 3 to 6 months, and then the aspirin, which is an antiplatelet, it is only sufficient. But in metallic valve, because it is whole made up of metal, so it is very high chances of thrombosis. So these patients, they almost always require the anticoagulation with warfarin. Metallic valve is usually used in younger patient. Bioprosthetic valve is usually used in older age patient, but that is not a very hard and fast rule. Sometimes the surgeon even use in different population. So surgery is indicated when the patient is symptomatic, having shortness of breath and all these things, and having severe MR. So this is the first indication. The second indication is when the patient has severe MR and the left ventricular function is impaired. When the left ventricular function is less than 60%, even if patient is asymptomatic, but the severe MR is there and the left ventricular function is less than 60%, then again the surgery is indicated. Or third indication is there if the left ventricle starts to dilate. When the left ventricular and systolic dimension, LVESD stand for left ventricular and systolic dimension. When the left ventricle diameter in the systole is more than 40 millimeter, we refer the patient for the surgery. So these are the three main indications for the surgery. Now comes on to the aortic stenosis. Aortic valve is situated between the aortic valve, between the left ventricle and the aorta. And normally it is a tri-leaflet. There are three leaflets. One is called the left coronary cusp, one is called the right coronary cusp, and the third one is called the non-coronary cusp. Now in aortic stenosis, when the valve area is narrow, because of the disease, the valve is narrow, we will call it as the aortic stenosis. Normal aortic valve area, it is about 3 to 4 centimeters square. And when this valve area is less than 2 centimeters square, we call it as the aortic stenosis. Now there are many causes of aortic stenosis. One of the common causes is the degeneration. And with as the patient gets older, then this aortic valve becomes thickened and calcified. So over the age of 70 years, degeneration, calcific aortic stenosis is the most common cause of aortic stenosis. In younger patients, the commonest cause is the bicuspid aortic valve. In congenital bicuspid aortic valve, so instead of 3 leaflets, there are 2 leaflets. The 2 leaflets, they get fused. So instead of having 3 leaflets, the patient have only 2 leaflets. One is the normal leaflet and the other one are the 2 fused leaflets. And this is called the bicuspid valve. And this bicuspid valve it is the commonest cause, it is the commonest congenital abnormality, and it is also a common cause of aortic stenosis in the younger age people. In those who are less than 40 years of age, the commonest cause of aortic stenosis is the bicuspid aortic valve. And this is more common in men as compared to female. The other causes includes the rheumatic heart disease. Another common cause, another cause is the infective endocarditis, but they are the less common causes. So here you can see this is the left atria, this is the left ventricle, this is the aorta, and here is the aortic valve. And this aortic valve, you can see it's become very much narrow. And because of this narrowing of the aortic valve, the left ventricle gets hypertrophy, thickened muscles develop there. So left ventricular hypertrophy develop in aortic stenosis. And also you can see it here. This is a aortic valve. This is a transverse section of the aortic valve. This is in the open position. So there are 3 leaflets. One is here, one is here, and one is here. So there are 3 aortic valve leaflets, which is a normal trileaflet leaflet. Now, if these 2 leaflets get fused, then we have the bicuspid valve. Here you can see we have 2 leaflets. One is here and one is here. This is called the bicuspid aortic valve, and it is the commonest cause of the aortic stenosis in younger age people. Here you can see this is aortic valve. This is quite thickened. This is quite, here you can see, quite thickened, calcified, and the valve area is very much narrow. So initially the patient is asymptomatic, and as disease progress, then the left ventricular hypertrophy starts to develop. When the left ventricular hypertrophy starts to develop, then the diastolic dysfunction may develop because the left ventricle is thickened, calcified. So the left ventricular pressure rises, and that causes a diastolic dysfunction. Ultimately, the patient may develop the signs of congestive heart failure. There will be, because of left ventricular hypertrophy, there will be increased myocardial oxygen demand, and that causes the ischemia. So the patient may have angina symptoms. In patient with aortic stenosis, because the valve area is very much narrow, so the cardiac output cannot be increased just like in a normal patient when the patient is exercised. So it is, therefore it is advisable in patient with aortic stenosis to avoid the exercise, because when they exercise, then because of the aortic stenosis, the cardiac output cannot be increased too much, and the patient may develop the hypotension and the syncope. Signs, symptoms includes, so in mild to moderate stenosis, the patient is usually asymptomatic. As the disease progresses, the patient may have the three cardinal symptoms. First, patient may have syncope, patient may have angina, or patient may have the signs of heart failure, the dyspnea on exertion. So these are the three cardinal symptoms of aortic stenosis: syncope, angina, and the heart failure. And if any of these symptoms, then the patient may have to refer for the surgery. Now, on examination, there is a very characteristic pulse is there, and normally the aortic, normally there is a, when we feel the carotid pulse, then we feel a rapid upstroke, and then the pulse becomes disappear. So normally there is a rapid upstroke in the pulse. This is a normal pulse diaphragm, and you can see there is a rapid upstroke, and then there is a downfall, and there is a dicrotic notch is there normally right there. So normally there's a rapid upstroke in the normal pulse, but in aortic stenosis, because the valve is narrow, so instead of this rapid upstroke, there will be a slow rising upstroke, and the pulse volume will be less. Here you can see the pulse volume is large, but here in aortic stenosis, the pulse volume will be less. So these are the two important findings on carotid pulse examination. These findings will be felt only on the carotid pulse examination. So the carotid pulse, there will be a slight delayed upstroke, and the volume will be less. And this is pulse is called the pulsus parvus et tardus, which is again a very important sign in case of severe aortic stenosis. The apical impulse may be strong and sustained. The apex speed will be strong and heavy. That will be a, you can say, is a heavy apex beat. This is a strong apex beat will be felt. This is because of the left ventricular hypertrophy, and the A2 sound may be diminished. So S2 sound will be diminished, and then there will be usually there will be no ejection click. And the most important finding is the murmur, and that will be a systolic murmur, because aortic stenosis happens in the systole, so the murmur will be systolic. So there will be a systolic murmur, and this murmur will best be heard at the A1 area, which is the second right intercostal space. Second right intercostal, it is just lateral to the left sternal border. This is the A1 area. So this murmur will appear at the A1 area, and sometimes this murmur may be radiated to the carotid arteries also. So we have to auscultate the carotid artery also. There may be a radiation into the carotid also, and this murmur may be long hollow systolic. So there may be a pansystolic murmur will be there. Sometimes the murmur intensity becomes as when the valve has become very much severely narrow, very severely narrow. So the blood hardly goes into the through the aortic valve, and at that point the intensity of the murmur will become reduced, and it will be difficult to hear sometimes, but usually there is a loud systolic murmur. The aortic stenosis is associated with the aortic coarctation of aorta. When the bicuspid valve is there, then there will be association with the coarctation of the aorta. So when we diagnose a patient is having bicuspid aortic valve, we must also have to look for the aortic coarctation, because the concomitant aortic coarctation is may be present in bicuspid stenosis. Here you can see on ECG, this is ECG precordial leads, and in precordial leads you can see there is a very prominent R wave in lead V6. This is the lead V6. So the left ventricular hypertrophy may be present on the ECG. The signs of left ventricular hypertrophy include prominent R wave in lead V5, V6, and prominent S wave in lead V2. So if we combine this S wave height and the R wave height in the V6, this combination is more than 35 millimeter, then we call it as the left ventricular hypertrophy. So we have to measure the small boxes of S wave in V2 and small boxes of R wave in V6. If this combination is more than 35, we call it as the left ventricular hypertrophy. This is the diagram of the transthoracic echocardiogram, and here you can see this is the left atrium, this is the left ventricle, this is the aorta, and this is the right ventricle. Now between the left ventricle and the aorta, this is the valve, and here you can see the valve is very much thickened. It is calcified, bright portions maybe seems to be bright, and the valve area between the two leaflet here, you can see there's a very small area. Normally the two leaflets are very far apart from each other, and there's a large area, but here because of the thickening and calcification, fibrosis, the valve area gets narrowed. So the valve area is narrowed, and we call it the aortic stenosis. So normal aortic area is about 3 to 4 centimeters squared. When the valve area is reduced to 1.5 to 2 centimeters squared, we call it as a mild aortic stenosis. When the valve area is between 1 to 1.5 centimeters squared, we call it as a moderate, and when the valve area is less than 1 centimeter squared, we call it as a severe aortic stenosis. Now comes on to the management. In aortic stenosis, especially if the patient has severe aortic stenosis, then we have to avoid the exercise which I have just told you. So avoid the heavy exercise. These are some drugs like diuretics. These should be used very cautiously because in aortic stenosis the valve area is narrow, so the cardiac output is already compromised. If we give the diuretic, then this will reduce the blood volume and the cardiac output may further be reduced. So diuretic, similarly nitroglycerin causes vasodilation. No, because cardiac output is reduced, so the blood pressure is mainly maintained with the peripheral vasoconstriction. So if we give the drugs which causes the peripheral vasodilation, then this can precipitate the hypotension and the patient may have the syncope. So the vasodilators like nitroglycerin or alpha antagonists, they all should be avoided. Similarly, the beta blockers, they all also be best be avoided because in aortic stenosis, the valve area is narrow, so it is the contractility of the left ventricle, heavy contractility is required to expel the blood from the left ventricle. And if we give the beta blocker, then that reduces the contractility, and in that situation, the patient become more symptomatic. So these drugs, they should be avoided in patient with aortic stenosis, and if they are compulsory to give it, then it should be used very judiciously, and we have to monitor the patient cautiously. Now, the main management for patient with severe aortic stenosis, and if the patient is symptomatic, like if there is a dyspnea, or if there is an angina, or if there is syncope, if any of these three symptoms, if any one of these symptoms is present, and the patient has the severe aortic stenosis, then we have to send the patient for the surgery. And the surgeon is do the technique which is the surgical aortic valve replacement. The surgeon open the aorta, he will remove the aortic valve and replace it with a new artificial valve. Again, that will be of metallic valve or the bioprosthetic valve depending upon the surgeon and the indication. If the patient is going for another surgery like for CABG, for bypass surgery, and if the patient has severe aortic stenosis, then again we have to send the patient for the aortic valve replacement. The third indication is the left ventricular ejection fraction. When the left ventricular ejection fraction is less than 50%, then again we have send the patient for the surgical valve replacement. So these are three main indications. One, if the patient is symptomatic. Second, if the patient is going for another surgery like CABG and having severe aortic stenosis, then we have to send the patient for aortic valve replacement. And the third, even if the patient is asymptomatic, but if the ejection fraction is less than 50% and patient is having severe aortic stenosis, then we have to again send the patient for the aortic valve replacement. Now here are some types of artificial valves. These are the metallic valve, it is mainly made of metal. This is the tissue valve, which is mainly in the tissue. And here again, this is a metallic valve, this is called the bileaflet. Now, another technique, which is a new, relatively new technique for the management of aortic stenosis, is the called the TAVI. TAVI stands for the transcutaneous aortic valve implantation. In TAVI is considered in those patients who are not good candidate for the surgery, like in old age people or having comorbids like renal failure, pulmonary disease, where the surgical risk is very high, then we advise the patient for TAVI. This is a percutaneous technique, and in this percutaneous technique, a catheter is passed through the femoral artery, then goes into the aorta. Retrogradely, this catheter then reaches at the level of the aortic valve. Then, when the catheter reaches at the aortic valve, then we pass this is a valve which is over the balloon. Then we pass this balloon which is have a valve over it, and then we place this valve at the level of the aortic valve, and then we through this balloon is it attached outside the body to a device, and with the help of that device we inflate the balloon. So when we inflate the balloon, then the valve which is over the balloon is then stuck to the this on the over the aortic valve. So then this new aortic valve
Excuse me,
now then
sir.
function. Yeah, yes.
सर कितनी देर आपको और ये चाहिए एक्सरे के लिए, क्योंकि टाइम ना अब हो गया है, 15 मिनट्स एक्स्ट्रा हो गए हैं.
अच्छा चलिए मैं कहा फिर एंड करते हैं, एओर्टिक रिगर्जिटेशन रह गया वो फिर हम या तो फिर बाद में
जी
डिस्कस
सर,
करेंगे.
ठीक.
ठीक है, कोई क्वेश्चन वगैरह तो नहीं? हेलो
जी सर जी.
कोई क्वेश्चन वगैरह तो नहीं है?
सर अभी तक तो नहीं, मैं देख रही हूँ चैट फाइल ना. सर 2 मिनट्स हैं, आप इसको रैप अप कर लें, और अगर कोई क्वेश्चन है तो स्टूडेंट्स पूछ लें.
I will just briefly go through the aortic regurgitation. In aortic regurgitation, the blood regurgitates back from the left, from the aorta to the left ventricle. And in aortic regurgitation, the murmur will appear in the diastole at the A1 area, or sometimes in A2 area. The patient symptoms like dyspnea, orthopnea, all that thing. And there will be a high volume pulse. A diastolic murmur will be heard. And again, the main management is the diuretics for symptoms.